What happened was I woke up in the morning about 6:30. I had pains in my neck, like as if you'd been sleeping overnight and you've got a stiff neck. Then I wandered downstairs, put some Ralgex on it, wandered back upstairs and went to bed because it was very early. But then the pain shifted and it went into just the shoulder blades, just at the top of the arm. I went downstairs and took another couple of headache tablets this time to try and get rid of the pain. Never for a minute thinking there were anything else wrong except I had been lying the wrong way in bed. Got up, got dressed, pain still didn't go away, so I started to think, maybe what's this? So I already suffered from angina, so I used the angina spray. Pain still didn't go away, so I phoned my daughter-in-law, who's a nurse. She came round, phoned 999, first responders. Unfortunately, they didn't respond first, it was the ambulance that responded.
When a patient has chest pain and they present to the doctor or to the emergency department, the first problem is sorting out, is this cardiac pain? The patient that we're discussing presented to hospital with what's called unstable angina, and that means that they had pain, but none of the markers of injury were elevated. So sorting this out clinically without another way of doing it was really a challenge. I'm chairman with a colleague from the University of Massachusetts in what is the largest international program in acute coronary disease of its kind. The whole idea of the program was to define the characteristics and the outcome of patients with heart attack and threatened heart attack to allow us to improve treatments and to produce improved scoring systems that could help the clinician in deciding who needs what treatment.
The GRACE risk model encompasses 8 variables into its calculation and get a score that is individual to the patient and will help to guide their treatment so that we really are prescribing their care and treatment rather than just guessing what their requirements are.
For patients like Elizabeth, who presented to hospital with the chest pain and who had many of the symptoms and some cardiograms, but she didn't have any damage to the heart muscle, our risk calculator shows that she was nevertheless at considerable long-term risk. And because of this, it was possible to do an angiogram test and find a very tight narrowing in one of her major coronary arteries and get this unblocked. So that worked really well.
I was taken downstairs in the afternoon, taken into theatre. I could see it on the telly, watched what they were doing. They put it in my arm, through to my heart, and discovered I had a little kink where I needed something doing, so I got a stent in. Taken back to the ward, I was fine, sat up after a little while, not very long, was allowed to have my tea. Then the next morning I was discharged at 11 o'clock, and since then I've been fine.
We've seen over the course of 7 years in this project in 14 countries reduced deaths, reduced heart attack and reduced new heart failure. Now when people arrive at hospital, the patient not only gets their clinical assessment as they did before, but they also get a form of risk score. Very recently, the new European guidelines have said it works so well that it should be applied across Europe and elsewhere.
Since I had the procedure done and I was discharged from hospital, my health's been fine. I can walk an 8-mile walk. I've had no angina attacks. I'm quite active. I do have a dog, so I don't take her long walks, but I do take her a walk every day. And I've been keeping fine. There have been no problems with my heart whatsoever, so I think I'm quite lucky.
British Heart Foundation has been involved in several aspects of this study. Because the BHF underpins support for my chair, it's allowed us to develop some of the new projects. It allowed us to develop and test the ideas before going out for major grant funding from elsewhere. And it also allows us to develop new ideas, and we've got exciting things in the pipeline for the next stage.